is there a more foolproof way to do this that takes into account different body habitus and all that kind of stuff, right? Okay, so momentarily we'll have to bring this down just a little bit more. All right. And so that's why I do what I do. All right, so I'm just going to mark this out right now. You know what? Let me just simulate that actually. Which one's the medium one? Yeah, okay. All right, so I'm going to try to mirror what I have on here if I can. All right, and then I'm going to talk through the sequencing. But as you've heard me, as I presented on earlier, I do this sort of like 4-line method, right? And that 4-line method is designed to basically take into account what's the easiest line to palpate first. Are there alcohol or something or other, or can somebody get me like a paper towels, please? A couple of little paper towel squares. But the lines or the landmarks are the easiest to palpate first. We do those first. Okay, thank you. And then we go from there. Yeah, you know what? Why don't we do that? Yeah. All right. So okay, wait. So this is what we're gonna do. All right. So I'm gonna go ahead and here. All right. So we're gonna go ahead and bring these down now. All right. So they gotta go down kind of far. Yeah. Yeah, I didn't want to do that. Okay. All right, so we do this. Makes sense. All right. We have the sequence 1 through 4. All right. I don't want to confuse that with what's the easiest part to feel first, like what's the number 1 easiest part to palpate and the second easiest to palpate. They're 2 different sets of numbers, if you will. All right, so I'm gonna go with what's the easiest thing to palpate, which is a little bit different than that 1 through 4 thing, right? So the easiest thing to palpate is the inferior border of the sacrum, way down here, all right? So I'm gonna mark that. I'm gonna mismark one of them, all right? Now, hopefully you can see this, all right? See that point right there where the gluteal cleft begins. That spot, and some of you have heard me say this already, that spot is actually quite consistent in human beings. I've seen 2 exceptions to this so far. There's 2 exceptions when I was in Santiago. But other than that, I have not seen any other exceptions to this. Hundreds of whatever low backs. My sense is that there is a fascial connection, a direct fascial attachment of that posterior aspect of the sacrococcygeal region and at bone actually to the skin surface. So it anchors this part of the body. I wonder if it has something to do with like the whole vestigial tail thing and all that in terms of our evolution. So that, oddly enough, the location of that spot, the beginning, the superior aspect of the gluteal cleft is a very consistent spot. The inferior aspect of that sacrum is about 3 centimeters inferior to that spot, and that's fairly consistent, right? Again, I've seen a couple of exceptions, right? But I would say 99% of people, that's what you're gonna see, right?
You said 3 centimeters?
But yeah, like 3 centimeters. Give or take probably a few millimeters, right? The vast majority of people mark somewhere up here, all right? And that's just wrong. Oh, can somebody get the bony model, please? The smaller bony, well, not smaller, but not small, but the one that's
pelvis with no
the pelvis with the, yeah, exactly, yeah, thank you so much. I can ask about that. Now, when I notice that people consistently make the same mistakes, like I see 100 people that all make the same mistake, I really start wondering, okay, clearly these people are not making stuff up with their fingers, they're feeling something, right? So what is it they're feeling? What is throwing them off? And that's actually kind of a fun exercise, because then you start really figuring out, okay, what's going on with the anatomy? What variants are there? What parts of the anatomy are masquerading for something else, where people think it's one thing, but in reality it's actually something else, and that's actually quite fun. Well, I think it's fun because I'm a freaking super nerd. So why is it that people are always marking more superiorly? It's because of the sacral cornua. That's I'm pretty sure, I'm like 90% sure that's what it is. So that's why I want to get the bony model, and hopefully the model has an intact sacrum. The sacral area is like a little bit wonky. But the landmark that how many of us do caudal epidurals, right? Okay, all right, so, and especially caudal epidurals under ultrasound, what is the thing that you look for under ultrasound? That frog eye view, right? Or what are the eyes of the frog? The eyes of the frog, those are the sacral cornua, right? By the way, cornu is singular, cornua is plural. And similarly, see, I also kind of enjoy all this kind of stuff with Morton's neuroma. What's the plural of neuroma?
Neuromases.
Neuromai?
What's the, okay, so not to get religious or anything, but what's that classic, the issue that, or not issues, basically the three things that, was it three that Jesus had? It was like the this, and the this. What do they call that?
Stigmata.
Stigmata, right? What's the singular of stigmata?
Stigma?
Stigma. So, what's the plural of neuroma? Neuromata. Neuromata. Yep. Yeah, interesting, right? Okay. So, okay. So these 2 points here, these are the cornua, right? The sacral cornua right there. So you can kind of appreciate how you might mistake this for this, right? So yeah, Monica, so you might mistake this bony edge right there. You'll think that this is that, right? And that's where you can make a mistake. So when people mark this too superiorly, it's usually because they're getting faked out by the sacral cornua, right? Now that's one piece. The second piece is probably cultural, to be honest with you. Especially in the United States. I know it's not the same in different countries, but it's like we want to maintain the patient's modesty, so we were afraid to expose the gluteal cleft and stuff like that. And you definitely want to help maintain their modesty, but you got to treat them correctly first, right? That's the most important thing. Yes.
Will you just state the rule again? The gluteal cleft is 3 centimeters above
the inferior border of that lateral sacrum, the inferior aspect of the lateral border of the sacrum. So it's basically like, it's kind of in that sacrococcygeal area actually. It's about like this spot right there. So that spot, which is about the most inferior portion that you can palpate for that area, is about that 3 centimeters, right? So this is actually pretty much the easiest bony landmark to palpate in the entire lumbosacral spine. It's even easier to palpate in larger patients than the superior aspect of the iliac crest, which by the way is number 2, the second easiest thing, right? So the easiest thing is this one. The second easiest thing is this one. So those of us that remember the ratios, and actually I was going to use that in a second, Mark.
I'll give it back. I'm fixing
oh, it's
it.
fixing. Oh, the screw came out. Okay, I got you. All right, I guess we're screwed, or not screwed. Anyhow, so by coincidence, the ratios that I was talking about, and actually I'm just going to go over that right now, and then we'll see what we cover on here. But the ratio I was talking about is great because you can actually take advantage of the 2 easiest bony landmarks to feel. So the way that I've modified the way that I mark lumbar spines now, when it's difficult, when it's a larger patient, is I'll mark this one first. I'll mark this one second, I do the ratios, and I immediately have some idea in the superior to inferior plane of where that inferior aspect of the PSIS is. Ooh. Yeah. All right. I love excuses to use my little thing here.
Oh,
All right. So. What's it?
Good job
Right.
fixing it.
So that thing right now, keep in mind that this drawing is purposely not correct, okay? But basically, that right there, that lower corner right there, which is on that 1 through 4 line thing that I have, is line 3, right? The ratio is basically halfway. I should probably bring that slide up, but anyway. So halfway between superior edge of the iliac crest and the inferior border of the sacrum, essentially. Halfway there, and it looks like it's a little bit more accurate on her right side, is going to be that line 3, or the inferior portion of the PSIS. And then the second ratio is you take the same superior iliac line right here, and then the line that you just drew, which is that inferior border of the PSIS, and halfway there is going to be the approximate location of your sacral base. On the model I've got, or on that thing, I've got it too high, so I'm going to purposely draw it like too high, something kind of like that, all right? So those are the 2 ratios. So I use that to my advantage. Now I kind of do little, like just small little lines first to give me a reference point for, okay, now I know where that inferior PSI is supposed to be. Now I know where that sacral base is supposed to be. Then I palpate and see, okay, does this match up, right? Okay, so make sense? Question?
David, you're saying that initial ratio was between 1 and a 3D, correct?
The ratios are not on this slide.
Gotcha.
The ratios are not on this slide.
Gotcha.
Yeah. This is just mistakes. This whole slide is just, this is how you're going to F it up.
Gotcha.
Right.
So 3D is mismarked, is that correct? On the picture.
3D.
On the bottom of the picture.
Okay. I think I
Should that
misunderstood.
be lower?
Wait. Okay, actually, I'm not entirely sure what your question was now. I think I confused myself.
So it's 3D, that inferior portion of the sacrum that you use
Yes.
to palpate.
Okay. Yeah.
Because
So
the gluteal folds end right there, and I was thinking that should be 3
Okay.
centimeters down from where. the
yeah.
picture shows.
So yes. Okay. So I apologize. I misunderstood your question.
No problem.
So your question was not about the ratios. Your question was about the accurate location of that inferior border. That is correct. That's what actually. Yes, that is what mistake 3D is, exactly. So 3D is basically showing that, yeah, that thing is probably not inferior enough. Yeah, that's the mistake that happens. Actually, no, that's not right. That's not right.
3D shows that
It's 3B.
these two are not
It's
like
3B.
on the same level,
Yes.
like symmetrically.
Yes. Now that's an impressive. So size matters. Oh my god, I love that. Oh my gosh. It looks like I've got an extension dysfunction. Anyway, so 3B actually addresses your point in that 3B, the inferior line is too superior, missing the coccyx basically, right? Or that sacrococcygeal portion of that. Yeah, so 3B indicates that it's too high. 3D indicates that the two lines left to right are not symmetrical. Yeah. So thank you for pointing that out. Appreciate it. Okay, anyhow, so I know I'm kind of not going by the numbers. All right, so now that we've discussed that, we've discussed the two easiest things to palpate, we discussed the ratios. Now I'm going to go through this. What time is it? Probably 8:50.
8:45.
8:45? Okay, so we got like 15 minutes. At some point when it's like maybe in 10 minutes, can somebody kind of peek out there and see how we're doing in terms of patient prep? That would be very helpful. All right, so.
I think rooms are ready, it looks like, when I was just out there, but there's no translators yet.
Okay, yeah, so we'll keep going until they're basically ready to go. We don't want, sometimes the issue is that they're waiting for us, and even though year after year after year we tell them, don't wait for us, just get the patients and the interpreters in the rooms, so hopefully they'll be, relatively on time. But we'll keep going until basically they're actually ready. All right, so number one, the iliac crests between left and right are not symmetrical. All right, so you can see how on my markings that they're not symmetrical, right? One side is too inferior, the other side is hopefully accurate, right? So, of course, to check this even on your larger patients, even on large patients, the rib cage, you can usually feel the ribs, right? And you go inferiorly, and then there's that soft spot, and you keep going down, and then there's that iliac crest. So even in large patients, you can typically feel the iliac crest, you can typically feel the ribs, so you know that you can find that soft spot in between. And then in the beginning, you want to go in and down to palpate that iliac crest. But as always, when you mark, you don't want to mark when the skin is deformed because it's going to throw off your marking, right? So if on this side, hopefully you can see, if I push in and down like this, and then I mark a line, and then I let go, look at how far it moved. It just moved superiorly, like 2 centimeters, right? So this is a critically important technical point that you want to make sure that you get down, because that happens a lot in the anterior hip especially. When you're trying to mark those two intersecting lines to get the intra-articular for the hip, a lot of times you gotta move the pannus over, you're like shoving skin over, then you mark and you let go, and now that line's moved like 2 centimeters laterally, and it completely messes up your ability to do that injection accurately, right? So make sure that if you have to go in and down, and you're like, okay, yep, there's the bone, and you feel confident where that bone is, one technique is you release the skin, and then without skin deformation, you go in one more time, and now because you know where that bone is, it's much easier to feel it when you don't have skin deformation, and then you can mark it accurately, and then when you let go, then you have minimal distortion of the position of your line. All right, so that concept, of course, applies to like pretty much everything on that slide, right? So number one, iliac crests that are uneven. Number two, anything around the PSIS, this is where like most of the mistakes happen, all right? Is trying to mark those godforsaken PSISs, right? So divided into 4 subcategories here, all right? So 2A, the PSIS is too wide, all right? Most of the time that's what happens. I don't have that's actually not that bad. Some folks, and you all draw circles and so, you draw stuff like this, right? That's not what it looks like, right? So the PSIS is a relatively linear structure. It's angled, right? So it's not straight vertical. I should add that one on there too. because my drawing's actually, yeah, is that it's technically not vertical, it's like angled a little bit. Those of you that saw me do that ultrasound guided injection of the thoracolumbar fascia yesterday, right? So when I had it in line to treat the deep fibers, the probe was not vertical, right? It was like slightly oblique like this, right? So, you know, it's a little bit oblique. Yeah, that's not on there. I should add that one. It's not gonna fit on the slide though. I figured it out. Anyhow, so being too wide, and look at how narrow that thing is, right? It's about the width of like a finger breadth or so, you know? So it's not circular. Maybe I should put that on there too. It's not circular and it's not super wide, right? And then to B, actually I'm just gonna go A through D and I'll kind of do them all at once. So B is that the PSIS is either too long or too short, that's 2B, right? So some of you have like these short little PSISs or these gigantic PSISs that are like, you know, 8 centimeters long or something like that. 2C is that the medial lines, so 2C here, the medial lines here and here are either too lateral or too medial. This one is probably the most important one because it helps you to determine the accurate injection of A and B sites. You have your sacral neuroforamen in here. There's like stuff you want to hit that's hard and stuff you want to avoid, right? So the accuracy of these medial lines is very important, and they're the most difficult lines to palpate, right? So this area is quite tricky. And what some of you saw me do is that I will just take my pen and I'll line it up with that gluteal cleft, because again, that gluteal cleft is actually pretty accurate. Now you gotta make sure that when you adjust the clothing, that the waistband of their clothes, it's not crunching the gluteals together, because that could potentially distort the line, right? So what you wanna do, actually I do it exactly like how I've got Monica here, where I have the waistline pulled, you know, pretty far inferior so that it's not compressing anything, and you just take like a cover, like a chuck or something like that, and you cover whatever you don't want exposed, but you gotta get that waistline down so it doesn't scrunch up the tissue. That's very important, right? So you take your pen.
One way that I remember learning it, just release the glutes.
Yeah, release the glutes. Yeah, and you gotta be honest, it's like, you know, when you take the pants down, it's like, there's like a little pop, I guess, when the tissue tension is released, right? Yeah, so thank you, that's a great point there, Rico. Okay, so I'll take my pen and I'll just do like this, right? And you look, and it's like, all right, well, in this situation, when I have marked on Monica, clearly the left side is too medial, and the right side, the right side is too medial, and the left side is probably too lateral, right? But you gotta look at this symmetry. And let me tell you, when people aren't used to looking for symmetry, and then suddenly you're like, hey, all right, I'm gonna start looking for symmetry, oh my gosh, you're gonna see all kinds of wacky stuff, you know? And I actually got kind of scared when I started doing this, because, and I, of course, I have nothing but respect for my instructors and my colleagues, of course, and everything, but, you know, I've seen 30-year veterans of prolotherapy screw this up pretty badly, pretty bad. Actually, it looked like this, where there was like, at least a 2 centimeter difference in symmetry between the left and right. Now it's freaky, you know, because it's just they're not looking at it, right? What's that phrase, like, you know, if there's something that you don't know to look for, it's like, well, it sees me, but I don't see it, you know, but it's looking at me, but I'm not looking at it. So that's what happens with the symmetry thing. So once you start paying attention to symmetry, it's like you almost can't unsee it, and that's good because it's going to improve your ability to accurately mark all this stuff. So that medial to lateral symmetry, the wideness of the PSIs, the length of the PSI. So you can see that her left PSIS is like too long, whereas the right one is too short, yeah? And then just the overall symmetry of the inferior aspect of the PSI, so 2D is here. So you see that one of them is too inferior, the other one is too superior, and all of these things are independent of one another. They might be related. For example, if you got a PSI that's too long, yeah, probably the inferior aspect is going to be too inferior, but not necessarily. You can have two PSIs that are exactly the same length in the superior inferior plane, but one of them is just cockeyed and the other one is correct, or both of them are off, right? So all of these things are, they're independent errors that you can make, right? By the way, in my experience with 2C, the toughest error to get correct, the medial symmetry of those lines, usually both of them are wrong. It's usually not just one that's wrong. I would say at least 80% of the time, probably 4 out of 5 markings that I see, they're both wrong. Now, one of them might only be wrong by a little bit, but it's usually both. Now, one of the reasons for that is the sort of parallax, right? Because you're standing on one side, I don't know if somebody has to come in here, but if you're standing on one side, you know, and depending on if you're left or right-handed, you're going to probably have a little bit of asymmetry because you're coming at it at an angle, you're palpating a little bit differently on both sides, right? So that's probably one of the reasons why both lines are incorrect, is because of that little parallax thing, right? Okay, so it's 5 till, anybody know how we're, okay, are patients in?
Oh, yes. Oh, no, not yet. You want patients on the beds?
I
can do
yeah,
that.
yeah, patients on the beds, thank you. Right. Okay, so 3 has to do, actually, here's the thing. From 5 down, all right, so 1 through 4 is SI, pretty much, right? 5 through 9, well, not so much 9, but 5 through 8, are lumbar. Really, the main thing with lumbar is the midline. I'll come back to that in a second. But so 2 is PSIS, 3 is the sacral ILA, the infralateral angle of the sacrum, right? So again, we have 4 different things that can happen. So one thing is that the line is not a straight line, right? As I've been saying, and I don't like this line. I need to change that because it's not a curve. It's actually an angle, right? So if you, I don't know if you all can see, but on our sacrum here, and I'll use these 2 devices. Hopefully I can get this to make sense. Actually, can somebody hold this? Okay, thanks. All right, so there's one angle and there's the other angle. See, so it's about, somebody should measure that. I'm sure measurements exist for that, but I don't know, if that's 0, it's probably about, you know, 30, 40, between 30 and 40 degrees or something, probably 35 to 40 degrees, I guess. So it's angled like this. It's not a straight line, right? Now you've heard me say before, hopefully you've heard me say, that if a line is not important for the accuracy of your injection in terms of being safe and being effective, like I don't care about that line. Like, you know, if your line's not accurate for something, it's not a big deal. This particular seemingly small detail is pretty damn important, because let's say that you do have a straight line like this, and let's say that straight line down here, your bony border seems like it's more lateral than it actually is. In other words, the real bony border is medial, but your line has a mark laterally because you only have a straight line instead of the appropriate angle. Well, now you're going to be injecting thinking that the bone is over here when it's more medial, and you miss and you go lateral and deep. Well, what's down there? Rectum, right? The second scariest thing I've ever seen in these brigadas was when, yeah, you can kind of drop down a little bit, was when, actually I'll show you this way. Was when a student had I think it was at least a 3-inch, it might have been a 4-inch, 22 gauge. They were going after this very superficial inferior edge of the sacrum, and they had the needle hugged. They had it hugged, and then we redirected, and they redirected medially about, I don't know, 15 or 20 degrees, and they hit the bony edge, and only about 1 inch of the needle was down. 3 inches the needle was exposed, and everybody just silently had this like, oh shit look in their face, right? So that's one of the second scariest thing I've ever seen, right? So it can happen, you know, if you don't mark that line accurately and you're not palpating accurately, bad stuff like that can happen. Now you perf that rectum, who knows what's gonna happen, right? You know, potentially bad stuff, especially with a larger gauge needle. That's the other thing. Use the smallest gauge needle possible because it reduces tissue trauma, theoretically reduces chance of infection. I don't know if that's ever been studied or not, but you know, makes sense, right? Smaller gauge needles, shorter needles.
It's a good rule of thumb. I hate to use, but like, if you don't have a good idea where your needle tip is in space in reference to the anatomy, and call a table trainer over at least, but like maybe don't advance, and maybe like, you know, kind of
do not be afraid to abandon
do some thinking,
shit.
do some figuring it out, but don't just keep advancing if you don't have a great idea of where your needle tip is.
Yes.
In reference to anatomy.
Yes. Okay, so B, C, and D. So the inferior line is too superior. We already discussed that. So that's the error where you mistake the sacral cornu for the infralateral border. The superior line does not bisect the PSIS. So this is where Andrew Koken has a different methodology when he does this. All right. Basically, when you are marking the posterior, the superficial posterior edge of the sacrum, it bisects the PSIS. All right. And then lastly, I'll just go over this and I'll show you what I mean there. 3D, the right and left lines are not symmetrical. So 3D, again, we talked about how left and right aren't symmetrical, usually in the superior to inferior plane. Now, that bisecting thing, when you look at the sacrum, okay, many bony, when we draw something, we're basically trying to make a two-dimensional representation of a three-dimensional object in many cases. This is one of those cases. The sacrum has a thickness to it, you see? So, you can mark the superficial posterior edge, or you can mark the anterior deep edge. So technically it's like two different lines, right? I like marking the posterior line for a few different reasons. Number one is that it pretty consistently bisects that PSIS. So it gives you a method of self-correction. Like if you're palpating that and you're trying to mark that line, but it is not bisecting your PSIS, it tells you that something's wrong. Either your PSIS marking is wrong, or your sacral marking is wrong, or they're both wrong. But it gives you a way to, it gives you a reference point, right? The second reason I like this line is because I want to err on the side of being too superficial and medial if I miss, right? Now, if I mark this line and that line is wrong, you have a greater chance of going too lateral and too deep because your line is already lateral, right? So I like to mark the more medial line, and if I happen to miss, well, I might be lucky and hit, if I'm aiming for this spot, I might hit bone, but I might be hitting this spot. It's like I have a little bit more margin of error, right? And if I go too medially, yeah, you know, you do have the sacral neural foramen here, but I'll tell you what, I'd rather hit the sacral nerve root than the bowel. And the other thing is, I actually purposely treat the sacral neural foramen. It's one of my favorite techniques actually in the sacral spine. So I do ultrasound guided sacral neural foraminal hydrodissections. They're super useful. And let me tell you, trying to purposely get, this will give you all a little bit of sigh relief, but purposely trying to get a needle into that sacral foramen is actually fairly difficult. It's fairly difficult. Sometimes I can barely get the damn thing in there, right? So it's not like if you just happen to be, you know, because we always talk about you're doing your sacral, your Hackett A and B and stuff. If you happen to have a vertical angle, you're guaranteed to be screwed, and you're guaranteed to hit a nerve root. No, it's probably not going to happen, right? The other thing is the nerve root is fairly deep inside that neuroforamen. So you might actually accidentally get the needle in the neuroforamen, but that sacral nerve root is about 3 centimeters deep. So you're probably not going to hit it. Now you might irritate the cluneal nerves because the cluneal nerves come out posteriorly. So that's why there's these holes. There's holes on the anterior, there's holes on the posterior. Anteriorly you get the sacral nerve roots, right? Posteriorly you get the cluneal nerves. So you might irritate a cluneal nerve, but honestly that's not a big deal. Better to hit the bowel, right? So, oh yeah, awesome. Well, there you go. Yeah, so you see, you got that thickness of that bone right there. Now, granted, that actually is where the sacrotuberous ligament lives, by the way. Posteriorly, you got the gluteus maximus, proximally inferior fibers. Sacrotuberous. What's deep to sacrotuberous? It's a tendon. It's the one that PTs love to talk about, even though most of the time they're not accurate. Piriformis, right? So piriformis. Yeah, cool. So piriformis is deep to sacrotuberous. By the way, I like to talk, so this is my last point and we've got to go, but I like to talk a lot about how two wrongs often make a right. When we do the iliolumbar ligament injection, most of the time we're wrong. Most of the time we're treating the thoracolumbar fascia because we're not deep and anterior enough. It's pretty hard to get to that iliolumbar ligament. So most of the time students are actually injecting the more superficial posterior fibers. That's thoracolumbar fascia, but it helps a lot. Why? Because that thoracolumbar fascia actually is very pathologic. So we think we're injecting iliolumbar ligament, and we think the pain is coming from the iliolumbar ligament, but both of those are wrong. The pain a lot of times actually comes through thoracolumbar fascia, and we're actually injecting that fascia, not injecting the ligament. This is another situation. We think we're injecting the sacrotuberous ligament, but in a lot of cases we're actually injecting the proximal inferior gluteal glute max tendon. And how did I figure this out? Because when you scan these things under ultrasound, a lot of times the sacrotuberous is relatively normal, but that proximal glute tendon is all tendinopathic. And you hit that spot with the needle, it's like, yeah, that's my pain, I feel the referral. So I actually think that in many cases where we think they've got sacrotuberous ligament dysfunction, it's actually glute max. I only figured that out like last year, so yeah. All right, so that's basically it. I know we didn't get through all of the points of the error thing, but these are the important ones. The PSIS, well actually the iliac crest, PSIS, inferior sacral border, those really are where probably 90% of the error is going to happen, other than accurately marking that lumbar midline. Super important. doing this bracketing technique and then bisecting your fingers is a nice technique in addition to doing other methods of palpation. Cool? All right, awesome. All right.